Sometimes we talk about the learning curve. How many cases do we need to pass the learning curve? Maybe in the first 13 cases is the learning period, and then the next 70, you will become a competence. And after 84, you may enter the phase of mastery. But the operation time is not the only factor to judge you as an expert. We have also to consider the surgical outcomes and the oncological outcomes as well as the functional outcome. Several factors are considered as the necessary factors to train a rookie into an expert. For my point of view, I think the training of a laparoscope surgeon is the same as training a robotic surgeons. We also follow the same principles. We have to keep the compliance of oncological outcomes and dissection along the embryological planes. And we also to discuss the morbidity and the mortality rate to improve our skills and find out fault we will make during the operation. And during the training, the trainee needs a tutor. And when you just start the robotic surgery, you have to build up your team. And it's better to have your team member keep the same team member. Otherwise, you are training and the training for the newcomer again. My hospital just launched the system 3 years ago. So I have my robotic surgery only for 3 years. And then my first case is the September of 2021. And you know, you have to collect about 111 cases to be an expert. I just performed 142. For now, I'm a rookie of expert. So that's why Siripong asked me to talk about the experience, how to overcome the learning curve, because I just overcome. And if you invite Professor Che to talk about this topic, he might forget everything. And you can see this photo, this picture. This is my initial cases. And this is my operation time. We can count 1, 2, 3, 4, 5. For me, I might need only 5 cases to pass the learning curve. So I will show you how my experience, how to pass the learning curve quickly. And for my robotic color surgery, it seems no obvious learning curve. But during the time, my console time or operation time maybe keep the same, not any reducing or shortening. Maybe I try to explore more advanced skills and more complicated cases. And I try to move to total robotic operation. Initially, I will hybrid with laparoscope. But after 10 cases, I move to total robotic. So that's why I cannot shorten my operation time. And also, I have the data of complication or readmission. Comparing to the traditional laparoscope, even during my early phases of robotic surgery, the length of stay are still shorter than laparoscope, and no conversion, and the readmission rate is also lower, and no mortality. So through these three factors, I will discuss the tips and tricks. I will suggest when you do the robotic surgery, you keep the same surgical principles as your laparoscope, but there are still differences between laparoscope and robotic. At first, the pose placement is different. And I have the fourth arm, so always remember to do the assistance by yourself. During my coaching for other surgeons, I found they frequently forgot they have fourth arm, and their assistants still help him during the assistant part. I try to remind him, use your fourth arm because this is the advantages of robotic surgery. Assist by yourself, you can create better counter traction, and you can shortening the operation time. And the power of arm is very strong. Sometimes you might accidentally injure the tissue with traction. And I still remember my first cases of robotic. I felt like I was drifting on a boat in a river. It's a barrier for entering robotic surgery. You have to get used to the space orientation. And you have to get used to the tiny, very tiny jet lag when you move your finger and you see the movement of the arm. Although very tiny, but you can still feel the jet lag, the lag between your movement and your vision. So the difference of laparoscope and the robotic, during the operation, I think the first barrier is the space orientation and a little bit dizziness sensation. So you can see the fourth arm. Always do the traction. Don't forget to use the fourth arm. By the traction, you can have better counter traction, and then you can advance through the embryonic plane very beautifully. At first, you might get used to have the traction by your assistant, but during the robotics surgery, you can do it by yourself.
Based on the foresight recurrence data, the highest incidence
follow the same plan as the laparoscope procedure.
in the Netherlands and 21%.
And only do the fixation when you see the plan. Don't create the plan.
So finally, Heidi Nelson came
And the
along
advantages
with
of
data from
robotic
Mayo Clinic.
is the very fine scope view, and you can easily see the
This
plan.
is about 1% in the open setting, and an incision shouldn't be any
And move
different.
the scope
But
as
during that
close
time,
as possible. You can see I have an assistant here to suck fluid or air away, especially when the patient has underwent chemoradiation. So during the TME, I will use two assistant ports, one for traction, the other for suction.
Certainly was done, but it kept, as I say, it kept the brakes on for quite some time.
And this is the anterior part of dissection to separate the rectum from the prostate. You can see the advantages of robotic. This side, during the laparoscope, it's easily to have instrument crush with the scope or with the assistant instrument. But during the robotic, you can do the very stable dissection.
We can incorporate clinical leads, doctors.
And you can see the bone wheel. Here is below
We'll just help it into our product
the
development
denovial fascia. And so the stable view
to make sure
and
any robots we
field
build
instrument
will
crush
truly
can help
satisfy.
you to perform a very nicely TME.
Not only the lead of the surgeon, but also the assistants and
The patient has middle rectal cancer. The tumor is quite huge, almost occupy the inlet of pelvis. What will you do to the patient? Maybe chemoradiation first to reduce the size. But it's middle rectum. And I found there is still space between the tumor and the pelvis, and it is T3. The capsule is intact. So there is still chance to do the operation. But if I have only 1 and 42 experience of laparoscope, I cannot do it very well. But by robotic, even my experience is still rookie. I can do the dissection very fine because I can have stable support. I can move the scope very low into the pelvis. I can create the space by good traction and counter traction. Especially don't grasp the tissue. Use compression. They will keep the mesorectum intact. So although it's a very expensive equipment, but actually it has benefit for the patient. And sometimes I can change the direction of the scope to have better visualization. So here is the final view of TME. The capsule is intact. So, considering find the tutors, usually when your husband just launched the robotic system, there will be no tutor. And you have to learn by yourself. Maybe observation is a good way to see and is to believe and is to perform. In Taiwan, we have workshops. My boss and I have conduct workshop to introduce the operation technique and the tips and tricks to our junior newcomer. And they will also share their video. Maybe we can discuss online to suggest them how to adjust or how to improve. But you can see all of them are male. Therefore, Lady surgeons, please pick up your phone and take a picture of this. We have built up a lady colorectal surgeon of Asia. And later we will have a monthly Zoom meeting. During the meeting, we can share the video or the technique together. Let us support each other. Okay. 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 How to have consistent team members? I will suggest you set up team and set up the standard of operation. And since you are new to the machine, your assistant, your OR nurses are also new. So I will suggest you to read the guidebook. Several informations are shown on the guidebook. They will introduce every detail of the machine. Whenever they encounter the problem, you can fix the problem with them, or you can offer them better solution. So my standard operation is I let the boom to have a very wide opening. I told my assistant to fix the arm in the middle for every case. Why in the middle? Ooh. What happened? The view rotate. Okay, the wider arm has better range of movement. The closed arms, the movement is limited. Okay. Oh, sorry. I don't know what's happening. Okay. Here. How to fix it? I'm sorry, please rotate your head. I want to show if you found you can reach the deeper area. Sometimes just lay down the clearance joint. And then you can move forward. That's the function of the clearance. Your assistant may not understand the function. So it's the function of the clearance. If you roll down the clearance, you can reach higher place. If you want to go deeper, you can move your clearance upward. They will increase the range of motion. And simplify ducking process. I usually have 5 minutes ducking only. I make it quick to show that 2 minutes, I have only 2 minutes. After I set up the trocar, I let in the patient cart, and the center is in the scope. And I work with my assistant together to ducking the arms. Let the arm wide open and use the patient clearance. And then I won't targeting. I just insert my scope through the assistant port, and then I can simply advance all the instruments together. I don't have to rotate the arm. So I skip the targeting. Since all the instruments go to the place, I set up the scope, and then I can start the operation. And it only takes 5 minutes. So simplify all the process, you can build up your team easily. So how to overcome learning curve? First, follow the same principle. And in the beginning, set up your team with fixed team members and understand your machine. Advance the scope as close as possible, and don't forget you have 4 arms at least. With the assistant 2 arms, you can 6 arms into the operation area. And nothing is impossible. Thank you. For my friend, Siripong.
Any question for the speaker?
Okay, thank you for sharing your experiences. I have questions from your point of view. And when you pass the learning curve of the robotic-assisted surgery, any benefit that you can use to improve your laparoscopic surgery better?
Very good question. Yes, definitely. Since you see better from the robotic view, you can see the plan. And when you go back to the laparoscope, you can also see the plan. So that's the feeling I got from my robotic surgery. You can improve your laparoscope skills after you do robotic surgery.
Any questions from the floor? Okay, thank you very much,
Thank you.
Professor.